Ну все. Хорошо. So, good day, colleague. I think that everybody who wants to listen this lecture is here now. Write me something in chat if you hear me and see me well. Do you see and hear me well? So, okay, let's start. Today we are going to speak about ear pathology and especially acute and chronic otitis media with complications. As one of the most common diseases in each age. So as you remember, ear consists of external, middle and internal ear. So external ear, it's pinna with meatus acousticus externus, yeah. Middle ear, it is middle ear cleft, it's eustachian tube and cells of mastoid. And inner ear that looks like cochlea, yeah, it's the part of ear where sensory cells are localized. Yes, in cochlea hearing cells are localized, and in vestibulum and semicircular channels vestibular cells are localized. No, before speaking about acute purulent otitis media, yeah, let's remember that main functions of ear are hearing, yeah, and balancing. And the process of hearing consists of two main functions and two main processes. Yes, is conduction and perception. So conduction, it's the spreading of sound through the air and the liquid of inner ear to organ of cortea, and perception is when hearing cells are percept, yeah, sound wave. So what is acute purulent otitis media? It is disease, a local manifestation of which it is acute purulent inflammation of the mucous membrane of auriferous cavities of the middle ear. For you to understand, yes, we have said that middle ear, yeah, consists of three main parts, yeah. Middle ear cleft, eustachian tube, and cells of mastoid. So that's why, due to this definition, yeah, in the case of acute otitis media, the whole inflammation of middle ear, including mucosa of middle ear cleft and mastoid cells, are involved in process. So otitis media, ear infection or inflammation, is one of the most common childhood conditions pardon, for which antibiotics are prescribed. When prescribe antibiotics and what antibiotics, we will speak a little bit later. Acute otitis media is most common between 6 and 24 months of age, or 2 years. Yes, by age of 3, more than 80% of child have been diagnosed. Yes, so you can see that it is very widely spread disease, and almost each child has at least one episode of acute otitis media in their life. So, etiology. The most common bacteria that cause acute otitis media, it's Streptococcus pneumoniae. Yeah, it's up to 50%. Then it's Haemophilus influenza, Moraxella catarrhalis, and group A Streptococcus. Yeah, common in all the children. If group A Streptococcus, beta-hemolytical Streptococcus, is the cause of the acute otitis media, yeah, it can quite oftenly lead to very quick perforation of tympanic membrane, and sometimes this perforation left persists, and with forming of chronic form of otitis media. So how infection can appear in middle ear? So firstly, it's renal tubal way. It is through Eustachian tube. It is the most common way. Transtympanic and hematogenic. Because of Eustachian tube connect middle ear with environment, yeah, it is can be quite often situation when infection from the environment through the Eustachian tube appears in middle ear cleft. That's why the normal functioning of Eustachian tube is the key position in normal functioning of middle ear. On this slide you can see predisposing factors of acute purulent otitis media development. And as in the most sorts of disease, we can divide these factors to general and local. General is decrease of reactivity of organisms, cold climate, unfavorable common and industrial factors, no being breastfed, recently illness of any type, genetic factors, and changes in attitude to changes in altitude or climate. And there are also local factors. Yeah, it is inflammation into nasal cavity, paranasal sinuses, and nasopharynx. Surgical interventions into nasal cavity, paranasal sinuses, nasopharynx, forces, anterior and posterior packing of nose. So that's why it is very important to make a correction of any pathological process in nose and nasal cavity to prevent acute otitis media in child and in adult. Here you can see a pretty good table. Yeah. So what we can see here, yeah, it's the legend, pathophysiology, mechanism, signs, symptoms, complications. Yeah. So here it's the risk factors. Yeah. and why these factors can lead to otitis. Here you can see signs and symptoms. Here you can see pathogenesis, and here you can see laboratory and here you can see complications. Yeah. So let's speak a little bit more about each of complaints. Maybe if you know or if you read the stages of the clinical course of acute otitis media, divided on 3 stages. Yeah, it's development of the inflammation, 1 to 3 days perforation, 4 to 7 days, and reparative healing or involution of the disease. Maybe it is more correctly to name the third phase, the phase of outcomes. Yeah, because except reparative healing and involution of the disease, it is we have in our practice some cases when the patients, instead of healing, had some sorts of complications. So, development of the inflammation. Duration 2-3 days. Usually it's before perforation or sometimes perforation is also absent on the background of antibacterial treatment. So what we can see and what complaints patient may have on the first stage. It is pain in the ear, otalgia, especially during the nights, sometimes irradiation into the teeth, temple, decrease of hearing, increase of the body temperature till 38-39, sensation of stuffiness and ear noise, sometimes pain during the palpation of the mastoid, reaction of the periosteum at the inflammation. So quite obvious picture. So it's how tympanic membrane is look like in the case of first stage. But as for me, this picture is more common for second stage. I later tell why. Colleagues, one moment, I'll come back. Well, and yeah, what symptoms we can see on the first stage? It's pain in the ear, yeah, otalgia, especially during nights, irradiated teeth, temple, decrease of the hearing, increase of the body temperature, sensation of stuffiness and ear noise. First stage. Stages of the clinical, the second stage, it is the stage of perforation. Usually it's up to 7 days, and during this stage perforation of the tympanic membrane is formed. The localization of perforation may be different, but commonly it is the anterior inferior quadrant. Purulent discharge from the ear appears, pain disappears but not always, and decrease of the body temperature is also not always. And the second stage is the reparative stage of healing, yeah, or the stage of outcomes. Normally you must know that in the most cases this stage is end with the full healing of tympanic membrane. It means that perforation is closed. And we can see decrease of the inflammation, stop of purulent discharge, hyperemia of the tympanic membrane disappears, perforation closed, yeah, and hearing usually restores. Sometimes we add to stages additional 2 stages, yes, because as we say that the main structure that protect middle ear is eustachian tube, and commonly all problems with ear start from dysfunction of eustachian tube, and sometimes some authors divide and mark the first stage of this acute otitis media as inflammation of eustachian tube or eustachiitis, yeah, or dysfunction of eustachian tube. And on this stage, the patient commonly can have complaints on feeling of pressure in ear and some feeling of disturbances in ear, but there is no pain. So, how to treat acute otitis media? Here on this slide you can see that antibacterial therapy, but frankly speaking, it is not it's not right, and not in all cases we start from antibacterial therapy due to protocols, international protocols. We consider that firstly, acute otitis media during first days, it's the viral etiology. That's why commonly antibacterial therapy in case of acute otitis is not administered from the first days. Exclusions from these rules are age, till to 1 year old, or very high temperature. Only in this case we may start from antibacterial drugs. In all other cases we start from non-steroid anti-inflammatory drugs, and maybe some local drops. So yes, don't forget it, and not start treatment of acute otitis media from antibiotics, especially in adolescents and adult person. So if we use antibacterial therapy, we start from semi-synthetic penicillin. It's the most common drug from this group is amoxicillin. It may be protected semi-synthetic penicillin with flavonoid acid, and it is the first line of treatment. If the patient has the problems with penicillin, for example macrolides, we can use macrolides. So macrolide is also the first line of antibacterial treatment, but if a patient has an allergy to penicillin group. If we start treatment and there are continuous some problems, or maybe complication appears, is developed, we can use cephalosporins and quinolones. And remember also one thing, that ototoxic antibiotics, such group as aminoglycoside, must not be prescribed in any age, especially in child, and especially in patients with problems with kidneys, because a lot of ototoxic drugs also additionally damage the kidney tissue. So remember, so such antibiotics as gentamicin, streptomycin, amikacin should not be used in case of acute otitis media, and in general try to avoid drugs and antibiotics among them that has possible toxic effects. The other very important group of drugs that we used during treatment is non-steroidal anti-inflammatory drugs, and commonly we start from this, especially if a patient has severe pain and high fever. And also we can use vasoconstrictive nasal drops to drain, to help eustachian tube to drain and to restore their its functioning. its functions. And also we can use local treatment as special drops for ear. Yeah, in the stage before perforation we can use Atipax or other similar drops that contain anti-inflammatory elements, usually anesthetic. But remember that almost all ear drops has a base, a spiritus, yeah, as the main component in which all other components are present. So that's why we can use these drops only the first stage, on the stage when the tympanic membrane is not ruptured. Yeah, because if you have a perforation in tympanic membrane and you drop spiritus drops in ear, it will be very painful situation for your patient. When pus appear in ear, it's very important to make a toilet of ear to remove all this pus. And on this stage you may use only ear drops on isotonic or physiological solution as a main substance, yeah. Because when you have a perforation in tympanic membrane, yeah, only water solutions are safe for patient and safe for unpleasant sensation. And during the third stage, when the tympanic membrane is restored, you, frankly speaking, you may do nothing and just periodically examine such patients. On this slide you can see the advantages of local using of antibiotics. Yeah, it's a vastly higher concentration of antibiotic. Medication delivered topically have no systemic effects. Topical delivery allows alteration of the local microenvironment, and autotopical medications are usually less expensive than comparable systemic. So what I want to say that duration of systemic antibacterial therapy must be as short as possible, yeah, and it is better to use local forms of antibiotics. Unfortunately, sometimes it is impossible. Here you can see what other methods can be used in treatment of acute otitis media. If the situation is not resolved, yeah, and it is still in progress, despite our treatment with antibiotics and non-steroid anti-inflammatory drug, so there is such procedure that we call, paracentesis or myringotomy. It means that we make a cut of tympanic membrane to drain all pus from the middle ear. Yeah, so you can see, so if severe throbbing pain, high body temperature and other manifestations of organism intoxication continue, To exist under appropriate treatment, and the tympanic membrane is edematous, bulging, hyperemic. Usually we use a special instrument and make a cut in anterior inferior position or anterior posterior, because it is the safest places on tympanic membrane to prevent any complications. Yeah, here you can see that incision of the eardrum performs on its posterior inferior quadrants with the special paracentesis needle. And of course, this procedure is done under local anesthesia. Sometimes it may be meato-tympanic anesthesia, and sometimes we can just lay a piece of something with anesthetics on the tympanic membrane in the place where we are going to do paracentesis. So here you can see indications for myringotomy. Acute circulatory otitis media with built-in drum about to perforable. Acute suppurative otitis media with small or high perforation insufficient to drain this pus in children with cranial and intracranial complications with persistent pain and fever 24 hours. Also, it can be persistent of pain and fever for 24 hours after treatment. So it's the indications for myringotomy or paracentesis. Also, it may be some forms of otitis media. In this case, if we have prolonged persistent of mucus in middle ear, we insert here special grommets tube. Also, it may be otitic barotrauma and in association with cortical mastoidectomy. So here on this slide you can see insertion of grommet tube. Yeah, here is you can see a grommet tube with different form, shape, color, and material. Complications of myringotomy. Complications depend on localization of structures of middle ear in nasal cavity. Yeah? Here is a jugular bulb. It's the situation when jugular bulbs stay very high in middle ear, and during paracentesis you may make a trauma of this. Sometimes the medial wall of middle ear can be damaged, but more commonly it's the I can't say not commonly, but quite often can be met jugular bulb. Also high position of jugular bulb. Very important part of management of with this disease is acute otitis media in infants. The rate of acute otitis in infancy and early childhood is much higher than in adult age. The high incidence of the middle ear disease in infants is usually regarded as linked with remnants of So the rate of acute otitis in infancy and early childhood is much higher than adult age. And the higher incidence of middle ear disease in infants is usually regarded as linked with the remnants of embryonic myxoid tissue filling the middle ear cavity, and most susceptible to suppuration caused by the entrance of infectious germs through the eustachian tube, which is wider, more horizontal and shorter than in adult. Mainly the rate of acute otitis is really depend on physiological features of eustachian tube in child. This situation, and also you know that all childs very like to be on hand, yeah, and we take a child in horizontal position, and especially when the child eats the milk, the breast milk in this position, it leads to possible appearing of this milk in the correction of eustachian tube, yeah, in nasopharyngeal ostium of eustachian tube. And of course it also may lead to inflammation of middle ear. Also, tympanic membrane has some peculiarities. In infants it's more thick than in adult. Because of this fact, perforation occurs during the late periods of disease. Yeah, here you can see how how eustachian tube is look like in different ages of child. Symptoms. Acute otitis in infants pass through the same stage as in adults. Since acute otitis in infants shows no adequate symptoms, it is often difficult to diagnose. No, understand, yes, because child can't speak, he can't say where he has pain or something like this, yeah, and sometimes it's very great challenge, yeah, to find the reason of complaints in small child. Usually meningeal symptoms are to be found, such as stiff neck, vomiting, common convulsions, no collected as meningism. And treatment. Acute otitis in infants is managed in the same way as in adults. On this slide you can see some features of acute purulent otitis media depending on etiological factor. Yeah, for example, after influenza we can see hemorrhagic inflammation with necrosis. If we're speaking about viral infection, it also can be such form of acute otitis media as hemorrhagic otitis. Yeah, and we can see here, yeah, with the forming of bullous with blood. Measles and scarlet fever. Unfortunately, in this form of otitis, the damaging of hearing function is very big. It's also possible that after this form of these types of acute otitis media, chronic forms will be developed. Measles is the first sign of inflammation of the middle ear, developed during late period of the disease, along with the complications from the part of larynx. First signs of the inflammation of the middle ear developed during late period of the disease, along with the complications from the part of the larynx, bronchi and lungs. Perforation of eardrum is seizable. Inflammation course of the middle ear is long-term. Complications from the part of the mastoid are seen. Treatment, antibacterial therapy. And as we say that it may be different outcomes, so it may be intratemporal infections, mastoiditis, facial nerve palsy, acute labyrinthitis, petrositis, acute necrotic otitis, and chronic otitis media, and intracranial meningitis, encephalitis, brain and subdural abscess, and sinus sinus thrombosis. So here you can see the very one of the most common complications of acute otitis media is mastoiditis. Mastoiditis is acute purulent inflammation of the cellular system of mastoid. And you can see the very picturesque picture when the ear from the damaged side become more lateralized. What causes of development of mastoiditis we can reveal? It's higher virulence of infection, decrease of reactivity of organism, improper treatment, bad drainage of exudate, and structure of the mastoid. Clinical feature of mastoiditis develops at 2-3 weeks, of course, of acute otitis media, and sometimes it can be situation that after healing, even tympanic membrane was closed, after several days, such patients return to us, with pain in the mastoid region, independent of or under pressure on the side or apex of mastoid, and very often such patients has very severe headache. The local system are mainly the same. So I think on this we end the first part of lecture. Okay, colleagues, a few minutes and we continue with chronic otitis media. Okay, colleagues, will continue. So as you know, we divide two forms of chronic otitis media. It's so-called mesotympanitis or epitympanitis, or more correctly, to say using international classification disease terminology. So mesotympanitis will be chronic tubertympanal otitis, and epitympanitis will sound like chronic epitympanoantral middle otitis. So what is chronic suppurative otitis media? Chronic suppurative otitis media is a long-standing inflammation of the middle ear cleft characterized by ear discharge and a permanent perforation of the tympanic membrane with or without permanent changes in the middle ear. Yeah. So chronic suppurative otitis media without stable perforation is impossible. Predisposing factors for chronic otitis media, its anatomical peculiarities of the middle ear, necrotic form of acute otitis media under infectious disease. Yes, what about we are speaking? So it's measles, scarlet fever, improper and insufficient treatment of acute otitis media and mastoiditis, decrease of the organism reactivity, allergic lesion of mucous membrane of the nasal cavity and eustachian tube, ventilation and drainage function disorder. But of course, also one of the main things is the normal functioning of eustachian tube. So clinical feature, what we can see: periodical atria, persistent perforation of eardrum more than 6 weeks, decreasing of hearing. Yeah, when we will be on our lessons, yes, we discuss audiogram. Yeah, it's the method that allows us to check the hearing function and to check what component of hearing is damaged: conduction or perception. And sometimes it may be other symptoms as ear noise, vertigo, imbalance, and headache. Yeah, it's tubertympanic or safe time, or aticaentral or epitympanoantral or unsafe form. Why one form is safe and why the other is unsafe, we will speak. So in the case of tubertympanic or safe, we have central perforation, yeah, of pars tensa without involving in process of fibrous ring, yeah. And if we are speaking about aticoentral form, yeah, always fibrous ring will be destroyed. Here you can see the division of tympanic membrane on 4 quadrants. Yeah. So it's anterior inferior, it's posterior inferior, superior anterior, and superior posterior quadrants. Yeah. So also tympanic membrane has pars tensa, yeah, and here is pars flaccida. Commonly, mesotympanitis characterized by slow, comparatively favorable course. There are no intracranial. Sometimes, of course, it is possible intracranial complications, but in the case of tubertympanal form, intracranial complications are quite rare. Patient complain on decrease of hearing and discharge from the ear. perforation of eardrum is central, and as I have said, some substances of tympanic membrane remains between the rim of the perforation and the bony sulcus tympanicus. Sometimes in the case of mesotympanoid oral polyps may be met, but it's also more common for articoantral form. And of course, if we have big perforations of tympanic membrane, of course it lead to bad hearing and conductive hearing loss. Articoantral form, articoantral form is characterized that with marginal perforation. Yes, marginal, it means that perforation is spread to fibrous rim, and commonly it's localized in pars flaccida here. Marginal perforation results from an acute necrotizing otitis media that destroys large areas of tympanic membrane, including the annulus tympanicus and the mucous membrane of the middle ear. This disease may cause conductive and sensorineural hearing loss and exacerbations of otolry, headache, vertigo, and ear noise. Commonly, articoantral form of acute otitis is matched with cholesteatoma. Cholesteatoma is benign collection of squamous epithelium and keratin debris in the middle ear. It means that the skin from the external acousticus meatus spread through the margin perforation into the middle ear cavity. Cholesteatoma may have a trial sign of debris along the canal or to the margin perforation, cause sensorineural hearing loss from mass effect and erosion, conductive hearing loss from mass effect and erosions of ossicles. And always this situation is treated surgically, because you must understand that these masses of squamous epithelium destroy the bone in the middle ear, and you remember that the wall that separate the top of middle ear cavity from the brain is very thin, and the cholesteatoma may erode this bone, and it will lead to intracranial complication. So the main idea of operations in this case: to prevent development of otogenic intracranial complication, eliminate purulent protests in the middle ear, and to save, if it is possible, the patient hearing. So before microscopic techniques using, the main idea of operation was to form the big cavity, with removing anything from middle ear. All ossicles was removed and formed one big hole. Nowadays, when we use microscopic technique, of course it is not the best variant of operation, and we must try to save all damaged structures. Here is pretty good table for deep diagnosis between two forms of chronic otitis media. You may do the screenshot of this slide. Yeah. Very briefly, one of the main differential diagnosis features are localization of perforation. If we are speaking about tubertympanal form, it's the central localization, and if we are speaking about eticoantral form, it's margin perforation. The features of pus is different. Commonly in the case of epitympanitis, the pus will be with very bad odor. It's because of cholesteatoma, because cholesteatoma produce different ferments that destroy bones, and these ferments and later the bacteria that become gross in this cholesteatoma lead to appearance of this bad smell. So, autogenous intracranial complications. Of course, nowadays when antibiotics are widespread and we often prescribe them, the frequency of complications obviously decrease, but sometimes still occur. The complications of otitis media include the following: meningitis, the most common, intracranial abscess, and sigmoid sinus thrombosis. So, how infection can go to intracranial cavity? Firstly, it's contact way. It's a result of bone destruction by carious process. It is how cholesteatoma lead to complications, yeah, by preformed ways through the superior of the tympanic cavity and mastoid air cells, labyrinthogenic, quite rare way through the internal ear, hematogenic under acute purulent otitis media, lymphogenous, and traumatic. Of course, the most common way is the contact and sometimes hematogenic. So, autogenous purulent meningitis. With meningitis, you will meet on different disciplines: neurology, infections disease, and here only main symptoms and main features of this disease. Bacterial meningitis is fairly easy to diagnose because of its presentation of headache, fever, neck rigidity, and abnormal reflexes such as Kernick and Brusinski sign, Lasek sign. If we are speaking about ear pathology, it can be met in acute otitis media and epitympanitis. So it's the inflammation, yeah, of meningeal layers, yeah. So, yeah, it's how infection contacts with meningeal layers, yeah. It is here you can see bone destructions with, for example, cholesteatoma, yeah, erosion of dura mater, yeah, with formation of abscess or meningitis. The predominant symptoms of meningitis is severe and generalized headache. The pain may radiate to the spine and lower limbs. The patient tends to lie quiet and immobile. Photophobia and general hyperesthesia usually occur. Early vomiting is common. Meningeal irritation is manifested by several signs. The neck is stiff even to the point of the nuchal rigidity. Neck stiffness has been described as the most important sign of meningitis and one of the most early apparent signs. Active flexion of neck causes pain. Passive flexion is resisted by spasm of the extensor muscle of the neck. Clinical feature, yeah? Kernick signs, Brudzinski signs. If we examine oculophandy, yeah, we can see nothing, but sometimes earlier papal edema may appear. And you must remember, yes, that nuchal rigidity is not seen in infants younger than age 6 months, but balding of the fontanelle is a frequent sign. Head retraction and opisthotonus may occur in children. When meningitis complicating otitis media is suspected, palpation of the fontanelle in infants and active or passive flexion of the neck in older patients should be performed during examination. Abscess, yeah, of cerebrum and cerebellum. These slides we can see the example of abscess. Diagnosing abscess of a cerebellum and cerebellum may be difficult or impossible depending on the stage of abscess formation and its clinical presentation. Unfortunately, commonly the clinical manifestation of abscess, obvious manifestation, appears only when abscess become very big and lead to dislocation of brain's structure. Before these symptoms may be very unclear, yeah, and non-specific, such as subfebrile temperature, headache. That's why we must remember about this disease not to miss. Yeah, here you can see the scheme of formation of different abscess of different localization. Any abscess, yeah, here you can see abscess. Any abscess has 4 clinical stages. The first stage is initial, manifested by temperature rises, drowsiness, and or loss of ability to concentrate, and headache associated with general feeling of malaise, nausea, and vomiting. These symptoms are subtle and frequently overlooked and spontaneously resolved after several weeks. Yes, as you can see from these complaints are similar to any inflammation. Yeah, when abscess progress and form a protected layer, yeah, the symptoms may reduce and resolve. So the second state is latent, yes, is clinically silent with no symptoms and lasting for 6 weeks. Yes, it is the stage of formation of abscess. But when the abscess is not very big and don't lead to dislocation of brain structures. During the third stage, enlargement, it is the manifest of abscess. The abscess grows and forms in the regions of the previous cerebrities and produce focal symptoms of mass lesions, seizures, or loss of consciousness. General cerebral symptoms, which develops as a result in the increase of intracranial pressure. It's headache, bradycardia, changes in functions of eye, rigid neck, and chronic signs, and symptoms of disorder of conduction system activity and subcortical nuclei. It's different. Hemiparesis, hemiparalysis, which are observed on the contrary to abscess temporal lobe side, facial paralysis, spasmodic attacks, pyramid Babinski sign, Oppenheim symptoms, and other. So you can see that unfortunately abscess clinically manifest only on the third stage when the abscess is quite big. Yeah, also it may be aphasia if the abscess is localized in left temporal lobe. Temporal ataxia, diadochokidelts, if the abscess is localized in cerebellum. Yeah? Here you can see an abscess. On the fourth stage is termination stage. The abscess ruptures into the ventricle, or abscess ruptures into the subarachnoid space. This results in rapidly progressive, frequently fatal outcome. Sigmoid sinus thrombosis. Yes, it is the inflammation of inner wall of lateral venous sinus with formation of a thrombosis. It's too big information for you. Yeah, so how infection spread? Usually after mastoiditis, or if cholesteatoma is localized in mastoid cells, it is the erosion of the bony wall and then expanding the infections to the sigmoid sinus. Lateral sinus thrombosis is notoriously difficult to diagnose. General symptoms seems like sepsis, yeah, it's hectic fever, tachycardia, paleness of skin, leukocytosis, elevated erythrocyte, sedimentation rate, anemia. And focal symptoms, yeah, it may be Griesinger signs when the thrombophlebitis spreads to the mastoid emissary vein, which communicates to the sigmoid sinus through the mastoid foramen. Edema and tenderness may be produced over the mastoid process. And for signs, whiting signs, yeah. But of course, these signs are not very specific, and in any case, if we suspect any complications, yeah, of acute otitis media or chronic otitis media, we need to do additional methods of investigation such as CT scan or MRI. It's everything what I want to tell you about diseases of ear for today. I remember you that visiting of all lectures allow you to receive additional points on your cycle, and of course it allows you to receive additional and structurized information that help you to prepare for your lessons. So good luck, and you have one more lectures in our discipline. So see you on the next lecture. Goodbye.